So my name is Alice Kong. I'm a clinical endocrinologist, and I'm very happy to this opportunity to share with you what I have spoken uh, during IDF Bangkok last month. And the title of my turn in diabetes. I would like to have a minor change of the topic to interconnection between sleep, depression, and diabetes. This is my disclosure. I didn't cut any of my slides, although I know I have less time allocated compared to my talk when I delivered the lecture in IDF. And so I will be a bit concise for each slide. I would like to highlight that the reason why I want to have a minor change of the topic, because these three conditions, sleep problems, diabetes, and depression, are really important and prevalent conditions, and these conditions are interconnected. Well, last month in IDF at the Bangkok, as one of the delegates, and many of us are very eager to know about the latest epidemiological data about diabetes prevalence, and happy to share with you the latest IDF Diabetes Atlas, the 11th edition, and not surprising to know the number of people with diabetes are increasing, and we have 589 million people are living with diabetes across the globe, and the number, expected to increase further by 2050 to 853 million. Many parts of the world, we have increasing number of people with diabetes, and in Asia, where we are staying, have a very, important increase, just second to Africa. And this I want to, highlight that diabetes is one of the four main groups of NCDs, non-communicable diseases, which killed 3/4 of people across the globe. And in parallel with this rising global prevalence of diabetes, there's also increasing number of people with sleep deprivation. No matter young people or, older adults, they increasing demand due to work or various commitment. We cut the number of hours per night to sleep. And from compared to 1 century ago, that the average hour of sleep per night is about 9 hours. Now that many of us sleep less than 7 hours per night. And also with modernization, we're actually facing a lot of energy-dense food, and also sedentary lifestyle, decreased physical activity. Also, we are having increasing stress, chronic stress. And in this sleep deprivation is in a kind of chronic stress. And I wrote this review article with my postgraduate students summarizing the evidence regarding mechanistic link why sleep deprivation can increase the chance of obesity, because when somebody got chronic sleep deprivation, that will activate our neurohormonal system, increase our cortisol, increase our sympathetic drive, increase the bad hormone, the ghrelin, that stimulate our appetite to eat, and decrease the good appetite regulating hormone leptin. And these work together to increase the chance to be obese. And once obesity sets in, there will be comorbidity like sleep apnea, and that grew as vicious cycle, further compromise the sleep quantity and quality. And my group and other researchers across the globe also demonstrate that sleep-deprived individuals increase chance to have dyslipidemia, and all these increase the chance of cardiovascular diseases. So I have to declare I'm a strong supporter of lifestyle therapy for diabetes management, and apart from the tradition, good diet, regular exercise, 100 minutes per week, exercise, behavioral, support with also smoking cessation. I'm so happy to, know that American Association of Clinical Endocrinologists since 2019 has included sleep as one of the components of lifestyle therapy. It was recommended to sleep about 7 hours per night with basic sleep hygiene, screens for sleep apnea. apnea. And 1 year later, actually, you are aware that it's more precise, a little bit change of the sleep duration to about 6 to 8 hours per night. I'll show you evidence why they have such an amendment. And indeed, for many, many years, we still not fully understand sleep. We all know that we need to sleep, but there's actually no consensus regarding the primary role of sleep. Sleep is proposed to play a role in learning, memory consolidation in our immune system, to fight the germs, toxin clearance, energy conservation, etc. As mentioned early on, why there's a kind of, change of this optimal sleep duration. I think one of the contributing evidence is from this Pew study, the prospective urban rural epidemiological study that include over 100,000 people across the globe in 21 countries, including Hong Kong, and with median follow-up about 7.8 years. And what they found, the optimal sleep duration is 6 to 7 hours per day, associated with lowest risk to have mortality and cardiovascular disease. And this U-shaped relationship, you can see that short sleepers associate with increased risk. I mentioned earlier on about the mechanism about neurohormonal dysregulation, why short sleepers have worse, outcome. Indeed, we are not sure why the long sleepers have worse outcome, and people postulate that extended sleep duration may be a marker of ill health. There might be undiagnosed cancers, undiagnosed depression. So we still not fully understand why long sleepers associate worse outcome. And I'm happy that I'm one of the researchers contribute to the body of knowledge regarding the association between sleep duration and also diabetes. And this is a study conducted in my team, including over 3,500 type 2 diabetes from the Hong Kong Diabetes Register, that we survey them and check the blood for glycemic factors, including A1C, fasting plasma glucose, and do questionnaire to survey their sleep habit. And what we found is a U-shaped relationship between sleep and glycemic control. And we can see that those short sleeper with short sleep duration during weekday, and also the long sleeper associated with high A1C. And also, the fasting plasma glucose also have a U-shaped relationship with the sleep duration between weekday and weekend. Well, this is the latest recommendation from American Diabetes Association, and then again you can see that sleep, highlight as an important, part of the diabetes management, and not only quantity is important, as you can see, optimal between 6 to 8 hours. The quality is also important, and insomnia is one of the sleep disorders that may affect sleep quantity and quality. And therefore, in my cohort, apart from studying the sleep duration, I also invite the participants to fill in questionnaire, the Insomnia Severity Index, ISI, and use 14 as a cutoff to screen for those with insomnia. And what we found in our cohort with type 2 diabetes with comorbid insomnia, they have worse glycemic control in terms of higher fasting plasma glucose, higher hemoglobin A1C compared to their counterparts without insomnia. So insomnia is one of the common sleep disorders. Also, we have sleep apnea and other sleep-wake disorders. I'm not so ambitious to talk all about them, and more focused in the subsequent of my talk about insomnia and diabetes. As mentioned earlier on, sleep, insomnia associated with worse glycemic control. Indeed, this is a very nice review article published in Diabetologia. Also highlight that insomnia in diabetic patients also have decreased quality of life, increased depression, and also increased retinopathy, although there's still a lot of unknown association, underexplored association between insomnia and other complications like nephropathy, neuropathy, and macrovascular complications. But what is insomnia? So insomnia is a prevalent condition. It is a dissatisfaction in the quality or quantity of sleep, with characteristics like problems in initiating sleep, in maintaining sleep, and frequent awakening and ability to return back to sleep. As mentioned, it's prevalent condition about 10 to 30% of the general population, and it's even higher in older adults. We do not understand the exact mechanism why there's insomnia, and it's believed to be a multifactorial disease. So why people progress from acute insomnia to chronic insomnia, and there's postulation about these 3P models, factors, individuals with possibly with genetic predisposition, with some anxiety, personality, and also with some precipitating factors like life events, stressor, from stress from work, finance, or other situations, and perpetuating factors with maladaptive coping behavior. And just want to, with this slide, to highlight the similarity about the 3Ps that for also for diabetes patient and insomnia. So also for the 3Ps, kind of common in also the link between depression and diabetes. And indeed, there's a bidirectional association between depression and diabetes. And from data from meta-analysis and systemic review, people with depression had nearly twofold increased chance to have type 2 diabetes. And compared to people without diabetes, the rate of depression, no matter type 1 or type 2 diabetic patient, also increased. Okay, so why diabetes and depression are related? And there's postulation about possible mechanism, including in depressive state. There's increased insulin resistance, and also during depressive state, there's a kind of stress and then activated neurohormonal regulations. So you may all aware the 2C and 2G catecholamines, and also the growth hormone, etc. are the counteract the action of insulin. And also depression have a negative impact upon patient diabetes, causing worse glycemic control, increased diabetic complications, increased, functional disability, and possibly with higher mortality. And this is a meta-analysis demonstrating that depression was significantly associated with a number of diabetes complications, including diabetic retinopathy, diabetic neuropathy, nephropathy, macrovascular complications, as well as sexual dysfunction. So now that we want to share with you a piece of data from my group that in Hong Kong, among nearly 600 Hong Kong Chinese with type 2 diabetes, we also studied whether they have depression using the questionnaire PHQ-9, and then we use a cut of 10, and then we found about nearly 9% of diabetic patients have depression. And those diabetic patients with comorbid depression, they have higher A1C, less likelihood to achieve A1C goal 7%, and also they are more likely to have self-reported hypoglycemia. And in our database, we also survey them with cardiovascular outcomes. So this is an analysis from my team that in the 7,853 Hong Kong Chinese type 2 diabetic patients without cardiovascular disease at baseline. And we studied them between 1996 to 2008. And after median follow-up of 7.4 years, we found that 153 of them were diagnosed with major depression by the psychiatrist after review of the case notes and also the database. And over 800 died, and then 829 developed cardiovascular disease, mainly due to stroke. And what we found is that you can see the solid line are the diabetic patients with major depression, and compared to their counterpart without depression, they have higher incident cardiovascular disease. And kind of similarly, diabetes with comorbid major depression also have increased incidence of stroke compared to their counterpart without major depression. So again, we are not surely understand why the mechanism linking depression, diabetes, and cardiovascular morbidity and mortality, and possible, behavioral factors like smoking, less physical activity, poor drug adherence, poor self-care contribute, as well as some pathological. So I want to share with you this very nice meta-analysis recently published in Primary Care Diabetes because I'm the editor-in-chief of Primary Care Diabetes, and I have the pleasure to, select this article and then publish it. It's a meta-analysis including 26 randomized controlled trials, including over 4,000 people with diabetes, aiming to evaluate whether cognitive behavioral therapy is effective in people with diabetes and depression. And what they found is that cognitive behavioral therapy is efficacious in decreasing the depressive symptoms. So we can see the significant decrease in the depressive symptoms. However, there's no significant association between A1C changes for CBT. So here I want to share with you the research question come to my mind, and that's why I have the funding to conduct a new randomized controlled trial aiming to investigate the effects of cognitive behavioral therapy, insomnia for people with comorbid diabetes and insomnia. And I'm very grateful to the funding body for me to have the resources to conduct this trial. And this is a study flow. And basically, I recruit Chinese type 2 diabetes patient, older adults aged 60 years or above with insomnia as evidenced by insomnia severity index 14 or more. And I randomized eligible participants into intervention arm with CBTI, basically 6 weeks, once per week with 2 hours per section. And then the control group will have the same contact time with usual care, but then they won't have any CBTI. And I study them at 3 months, 6 months, 12 months. And just want to share with you the interim analysis that you can see the orange line represent the subjects randomized to the intervention with cognitive behavioral therapy for insomnia. And you can see the A1C reduction with a trend from 3 months, 6 months, but then, at 12 months, it has a rebound. So I think there's a kind of learning from this study design that we only have the intervention in the first 6 weeks, and then without any subsequent measure to engage the patients, the participants, and so we have a rebound at the end of 12 months. And so another slide to summarize. Indeed, this is going to be published in General Diabetes Investigation very soon online, and work with my collaborators from Copenhagen, Dr. Phelan Mackles, and also psychologist Dr. Wing-Si Chen. And we summarize the evidence why there's a link between insufficient sleep, extended sleep, or circadian disruption like shift work and other sleep disorders like insomnia, sleep apnea. All these work also contribute to the etiology of diabetes and also increase the cardiovascular events and mortality. And indeed, there's a bidirectional relationship between sleep and diabetes. I mentioned about how sleep impact on glycemic control, but also in people with diabetes, they might have nocturia, that they wake up in the middle of the night to pass urine, that will interfere with the sleep, and also some of them may have complication like painful neuropathy. That pain is really a problem, because as you can see from this cartoon, when somebody got pain, that will actually cause anxiety, depression, and interrupt with the sleep, and that will result in all these associations. So I know I a bit overrun, and then this is the very last slide to summarize the message I want to convey to you. Number one, sleep problems, depression, and diabetes are all prevalent conditions, and they are interconnected. And sleep quantity, insufficient sleep or extended sleep, sleep quality, circadian disruption, sleep disorders like insomnia impact negatively on our energy metabolism. And there are data from systemic review of randomized controlled trials showing that cognitive behavioral therapy significantly reduced depressive symptoms in diabetes with comorbid depression. And I'm happy to share with you the interim analysis of RCT, from my team that suggests that CBTI result in a trend of A1C reduction, but then there's a rebound. And so I would like to end by acknowledging all my team members and collaborators, and also would like to cordially invite all of you to join the East Meets West Symposium to be held in Hong Kong, September 27 to 28. And for those who are interested, please hook on to our website or scan the QR code, and then I look forward to welcome you in Hong Kong. Thank you very much for your kind attention.